So the product you're using is Restylane?
This is normal, old-fashioned Nasha Restylane, 1% crosslink. It says Aldous bricks and as reliable. So starting point would be this line, which is invisible if she's just sitting up straight.
Right, correct.
But squeezing the skin will reveal the linear weakness. And you will see that if you hit the dermis and you inject a few strokes adjacent, you minimize the length of that line immediately.
Yeah, you can see the difference almost immediately, absolutely. And you're spacing those injections about how far apart?
It would be about 2 or 3 millimeters.
So they don't have to abut one on the other. You're really creating structure within the skin.
Absolutely. And the good thing is that we know from research from 2007 done in Michigan that the fibroblasts in the skin will be stimulated to produce more collagen. So in fact, the pattern I'm making now, which is creating stiffness in the skin or strength in the skin, will be followed up by the same pattern, but then in collagen.
Right, neocollagenesis. The patient's own collagen will take over.
Absolutely.
And you follow that down as long as you see that break in the skin.
Yep.
Excellent.
And we all know that as we age, like halfway down this line, because of the ligaments holding the skin up to the underlying structures, there will be a demarcation. There will be a fold at some point. And this is reducing that fold by strengthening the dermis.
And so what you're doing is you're targeting the mid-dermis when you do these injections?
Yeah. If you want strength, you need to target for the strongest layer in the tissues, which is mid-dermis.
It's just a beautifully delicate technique because you're only depositing really micro droplets as you're doing it.
Yeah, the amount of gel that actually goes in is minute.
I mean, if you show them the syringe right now, you've put in, I think, with all those injections, maybe...
0.05. Yeah.
Right.
And that's
Haven't even
all
used
you need.
0.1 cc's yet.
Yeah. And the question I get from people is, well, do you charge more because of this technique taking more of your time?
Time, right.
Yeah, you could.
Yeah, I'm a type that charges for the procedure rather than per syringe, because it really is expertise and time that the patient is benefiting from.
Yeah, and it's weird how it came to be a normal way of charging, of course, charging by the mill.
Right.
I mean, like if you do surgery, you will charge by the amount of sutures you're
Correct.
going to use, right?
Correct. But I mean, that's when the products came out originally, I think. You know, the companies were the ones that sort of directed us towards that because how much product could you use? It was only for nasolabial folds, so you'd use 1 or 2 syringes, you charge per syringe, but now we're all over the face. And it really is a question of time and experience and expertise. So you keep on tracing these things across wherever you see that there's breaking in the skin or where there's loss of integrity, I should say, of the skin envelope.
Absolutely. Wherever I see a weakness that needs to be strengthened, in my opinion, there's room for strengthening.
Now, people would ask, I'm sure, about longevity of result as well because of the fact that you're tracing such small amounts. What, in your experience, do you find that you tell patients what they should expect as far as the duration?
I tell them that they should expect to come back after 3 months to do a second treatment. But that's because I need to build up that collagen in the dermis. The other thing, once you're there, expect to come back every year for a touch-up, not a retreatment. And one of the first models I did use in 2005, I guess, in my presentation, he forgot my name and he came back after 18 years
18 years.
with a face that was not as severely damaged by acne scarring as in the beginning.
I mean, the studies originally that were done have shown that if you actually repeat the treatment within a period of time of about 2 or 3 months after the initial treatment, that you actually get a secondary boost that lasts longer.
Absolutely.
So Tom, why is it that you leave the bleeding as it is and that you don't wipe it off?
Well, the idea is that if you would wipe it off, you interfere with the blood clotting that just started. And what you see, if you wipe it, you see that all those little injection points will bleed again on the outside, but probably also on the inside.
Correct.
So if you just leave it for an hour or so, then clean it up, I think she will be less bruised than she would be if we try to vigorously clean her now for no specific reason other than the camera, right?
Okay. It also gives us a beautiful demonstration of exactly where you've injected. It's almost, you can see the grid pattern that you're doing as you're coming across. Constantly checking with your free hand to see where the skin is buckling.
Absolutely. And every injection, if put in the right place, will change the way the skin moves. And I always tell to my delegates when they come to a course, it's like mopping the kitchen. So you inject in this direction, coming from that direction, so that if you strengthen this line, for instance, you don't interfere with the visibility of that weakness.
And the actual pressure on the plunger, I mean, it's very, very slight because I see that you've probably used maybe 0.15 or so of product, and you've already done most of the cheek. You're working on the nasolabial fold now. But is it an anti and retrograde type of injection, or are you pushing the product forward and backwards, or are you
Only backwards.
only as you withdraw, retrograde?
Yes. The thing is, I want the gel to be where the gel does not want to be. I want the needle to be in the area of highest resistance. So I want the needle to stick where it doesn't want to go.
Right.
And people who are experienced with intradermal suturing know how it feels to grab onto that tissue,
Yes.
to have an effective take.
Right.
That's where you want to be. So that means if you would do an antrograde injection, you will ask the gel, okay, where do you want to go? And gel
Right.
will say, well, let me go to loose connective tissue because that's the easiest.
Correct.
Then it will give volume, not strength.
So you're actually filling the channel that you create with the needle with the product.
Only that. Then I'll step over to your side.
Please, we'll change. I'll walk around the back over here. And that's about the typical amount that you'll use for a sort of a cheek, so to speak.
Yeah, for strength, yeah. And she has a very delicate skin, so I don't need more. And whatever's left will be for her volume. So most patients in my clinic, they use one syringe only for one treatment. And if they need more, I would rather see them in 3 weeks or 3 months,
Right.
because the collagen will be stronger by then.
You probably feel it with your needle as you're going in, that you can feel this collagen that's built up.
Yes, you do. And you do see less bleeding the second time.
So are you planning to do any type of volume replacement on this patient at all, or is it mostly a...
Yes, I did feel there's a lack of volume here.
But this is the way that you start in your syntax. You always start with the skin envelope first.
Absolutely. The thing is, if you would do the volume first, you don't see where the skin
breaks are.
needs... Yeah, exactly. So you want to have a clear vision of where the skin strength is needed. And volume is something you can actually feel with your fingertips, whether the envelope is reconstructed or not.
Yeah, it makes sense. I guess you're ironing the sheet before you go ahead and fill the mattress.
Yep.
And you're working in the marionette zone right now. again with the same. The needle really doesn't go in that far. It's really only about, I don't know, maybe about a quarter of the length of the needle. And you find that the needle that's supplied with the product is really ideal for this?
Yeah, I like this needle, and I like to, other than, I've seen you do it, like transfer the gel into other syringes and stuff.
Right.
What I like about using the same needle and the same syringe all the time, the same gel, is that I feel I become more sensitive to the variations in the patient.
Right.
When I change nothing but the patient.
Right. So you standardize your technique, and by standardizing your technique, you can feel the differences in the patient's different skin. Right. Absolutely. And they're ultra thin wall needles. I mean, they're very good, those needles. So they certainly don't seem to dull at all very much.
Not much. It doesn't bother me.
Yeah, she seems quite comfortable.
She's
too.
comfortable, so yeah, then we're good. And when we come to the point that it is bothering her or me, then we can change the
needle. Mm-hmm. So how would you say this differs from, I know that in Europe, mesotherapy is something that has always been quite popular, but that's using a non-structuring product at all, I guess. It's just more of hydration issues.
It's hydration, and it's a non-structuring addressing.
Mm-hmm.
So it's a global treatment. Like you know, what we have now is Profilo, for instance. You have
Correct.
a global treatment of skin, which is helpful. But if you look at a cheek like this, there's a very distinct lack of strength. So if you want to reduce that variation in strength, it's more effective to aim for the weaker points than aim for everything.
The idea of what you're doing right now is filling in just areas that you feel that there's still a little bit of loss of integrity?
Yeah. And sometimes you will actually make a pattern that looks like a fern leaf.
Mm-hmm.
And sometimes when you've done one side, it's like this, there was a line here, and if you squeeze now it's gone. So you don't need to do the other half of that. And actually it's very simple. As soon as you get acquainted with the technique, is you don't need to plan ahead or to think. It's just I'm responding to what the skin is asking me to strengthen, rather than make a plan ahead about what she needs for rejuvenation.
So it's a very much of a feedback type of issue, because what you're doing is you're, exactly as you say, you're treating the areas that are showing you that they still need a little more structure as you go along.
Yeah.
So the results that you're expecting are rather immediate in most cases.
Well, absolutely. And of course, after this, you see by the redness, there will be some swelling.
Mm-hmm.
And the thinner the skin, the weaker the skin, the more swelling you will have. So the first days it will look weird, because you get the opposite effect of what you actually want. It looks good first 10 seconds. Then when the swelling gets in, it will be the opposite of what you actually want. Then after a week, it comes back to your end result. You see the improvement of the jawline. And what I want to see in her face is, like when we started, there was the transition from cheek to lower eyelid all the way down to the nasal jugal groove. And I want to clean this up and make the cheek
confluent, yeah. Mm-hmm.
Because anything that happens here makes us look tired, right?
Absolutely.
And especially interesting is, of course, the transition from this cheek to the lower eyelid.
This is probably where the technique becomes a little more, shall we say, intense, because the skin is getting rather thin up there.
Absolutely. This is not where you would like to start.
Start, yeah. I would imagine for novice or intermediate injectors, or those who are starting to take on this technique, that they should a good area to start would be where you did, actually, lateral cheek, and extend our way down towards the jawline.
Yeah, the most effective and simple indication would be the nasolabial fold.
Mm-hmm.
Because that's a thick skin,
Right.
very forgiving, very effective.
Mm-hmm.
Um,
And do you vary the amount per injection when you get to that type of area?
Well, whatever, I mean, the monitoring is all in squeezing. Whatever you need to make the skin stop moving.
Right.
That's it. Are you okay?
Yeah.
Cool. I will change my needle now. I'll change the area. I'll go to the other side of your face.
Are there any areas in the face that you will not do this technique? I mean, will you do it in the forehead if you had to?
Well, absolutely. We'll be seeing the other patient who has a beautiful frown line and a sleeping line.
Right, those crunch lines.
Yes.
Those are tough.
No.
Well, they're tough for most injectors. For you, they're going to be easy, and that's why we want you here.
And of course, there's a lot of talk about no-go zones or arteries and occlusions and stuff like that. As long as you know you're in the dermis, you're safe.
It's all a question of depth. I agree with you 100%. So we're going to repeat the same thing on the opposite side. Again, your pattern might be a little bit different depending on what the skin shows you.
Absolutely. And I've come to the phase now with my patient that they just sit and say, okay, do my face.
To your face.
And we're not even talking about which indication or what zone, or just do whatever needs to be done.
It's really a rejuvenative type of thing, and regenerative, I should say. You've used a total of what, 0.3 cc's, is that it?
Yeah, 0.25.
0.25, and that's typical.
Yep.
So as you said, you could do a patient with one syringe, entire face.
Entire face, yes.
So it's really micro threads that you're doing. The true ferning was starting from the actual, as we were talking previously, was starting from the actual line and then ferning outwards. So you're doing half the fern now, and then when you switch sides, you do the other half. Is that how it works?
Yeah, that's how it goes. And if you need to make a decision about which direction you want to do first, I would say fern the weaker side first, and then the stronger side.
Mm-hmm.
You see this line? It's gone.
It's already obliterated.
Yep.
So you're getting double effect. I mean, you're getting the effect of the product, which we know when you stretch the dermis that you're going to get that collagenesis. We know the fibroblasts respond to that. And you get the little trauma of the needle at the same time that's doing almost like microneedling.
Absolutely. The thing is, if you try this with a weaker hyaluronic acid, the effect will not be as beautiful as with this tough product.
So you've tried some of the newer products, even the ones that do come from Galderma, the refined, defined type of products, and yet you still prefer to use the standard Restylane, the Nasha.
Absolutely. And it's way tougher than all the other ones. And this is why some people try to use something which is softer.
Right.
But then again, if you ask a soft gel, where do you want to go? It's flowing away from where you want it to be. It's flowing away from where it is effective and giving strength.
Yeah, it's difficult to cross-strut with a soft gel. There's no question about that.
And of course, it's forgiving.
Yeah, the fact is I don't see a single bump. I mean, you know, obviously you're very experienced at this and been doing it for a number of years, to say the least. And I think for injectors that are going to try this technique, you'll notice the way that the plunger of his syringe is not at the tip of the thumb, where he's using the long tendon of his thumb to go ahead and to press on the product. He's actually using the small muscles of his hand at the thenar eminence just to kind of squeeze the product. Is that it? Just thinking in terms of squeeze rather than push.
Oh yeah, oh yeah. I mean, the amount needed is so minimal.
And that's why you're not getting any type of bumps or people get all caught up on this Tyndall effect. I mean,
Tyndall, yeah. I mean, Tyndall is, well, the great misconception, I think, is Tyndall. If you ask people, they will say Tyndall comes from too superficial placement of hyaluronic acid, right?
that's what most people think, but I don't agree.
Yeah, I don't agree either, because I think Tyndall comes from putting the needle in the subdermis, where it's too easy to lay too much material.
It's thickness of product,
Yes.
no question.
And so the most Tyndall effect we see is in lower eyelids, because people
Subdermal and thin skin?
subdermal, and there's no resistance in the tissue at all.
Mhm.
So it's too easy to lay your gel and to leave the gel in large quantities in loose connective tissue.
Absolutely. I mean, you use the analogy of looking at the ocean. If you're in the deep part of the ocean, it's dark blue because of the fact that there's depth over there. But when you're standing at the shore, the water is clear.
Mm-hmm.
So if you keep the layer quite thin, if you keep the product from bunching up, you won't have a Tyndall, which really isn't a Tyndall. It's more of a Raleigh scattering is really the right expression, but everybody's caught up on Tyndall, so we use it.
And when I have a class, there are certain words that I don't want to use and I don't want to hear. Words like superficial,
Mm-hmm.
which is giving no information about what layer you are in.
Right, superficial injection.
Superficial doesn't say anything.
Like jawline.
Yeah, like jawline. Stop using that word, because it doesn't help you. I mean, if we're trying to communicate, stop using jawline. Or things like, what do you do for deep nasolabial pulse? What is deep? I don't know what deep is.
It's all relative.
Yeah. Is London far away? Depends on where you are, right?
Absolutely, point of reference, no question. So this takes you, typically for a patient in your practice, you spend
30 minutes.
half an hour usually, about 30 minutes per patient. I wouldn't call it an arduous technique, but it's definitely a very specific technique.
Yeah, you can call it arduous.
Well, arduous maybe on your back, but certainly not. The patient seems to be quite comfortable. She was prepared before with some cream on her face, to topical anesthetic, to go ahead and to diminish the sting of those little injections. That's your typical way of proceeding, correct?
Yeah, if you look into my daily practice, my waiting room is all filled up with people in numbing cream.
With ghosts.
Yep.
People all numbed up. And you leave it on for about how long before?
30 minutes.
Mm-hmm.
I mean, 45 or an hour would be more effective, but nobody has the patience to do that.
Right.
If people want it, I'm happy to accommodate that hour for them, but most patients are happy with 30 minutes,
30
that's
minutes.
fine.
Absolutely. It's a beautiful technique as you see the symmetry of his little lines, his little pokes as he's going through here.
And you see here some Tyndall effect from the previous injections. So what I'm trying to do is to make sure that the skin will regenerate and produce more collagen, and that we will have like a touche éclat built into her own skin,
Mm-hmm.
minimalizing the transparency of that dermis.
Absolutely. Sometimes patients come with quote-unquote Tyndall because of the vessels under the skin.
Mm-hmm.
And I would imagine this technique improves it. It lightens them.
Absolutely.
You can see the different thickness of the skin as you're engaging it, as you get
This
closer.
is real thick, right?
Yeah.
Yeah. In comparison to the lower eyelid.
It's almost like a little scooping technique, a little swoosh that you do as you put the needle in. You kind of lift the skin up a little bit, I guess.
Yeah, if you try it, you will find that the skin tries to escape from that needle.
Right.
And it's almost like going to a barbecue and you have one hand and you're supposed to make skewers. You chase the way the skin moves away from your needle.
Mm-hmm.
And then you test where the needle is by pressing it down. Because this will tell you that, like the tethering effect,
The little puckering that you get shows you
Yeah.
you're definitely intradermal.
then you're intradermal.
Correct.
And let's make a mistake on purpose. This is subdermal. If you press it down, the needle doesn't drag the skin down. So being more superficial, that's more effective. So that's your optical
Feedback.
You got, of course, the feeling of resistance on the needle. That's your first feedback. And the more resistance you feel, the more effective in terms of strength the injection will be.
So it takes you a half an hour to do a patient's face, and then they sit and sort of percolate in your office somewhere for how long afterwards? About 45 minutes or an hour, where you don't wipe off the blood on their face.
Oh, no, they go home.
They go home.
Yeah.
They go home all dotted like that?
Yeah. Yeah. And
Well,
like with the pandemic, we had masks, right?
Oh, now that must have been a big boon to your practice to have the masks.
Absolutely. Now, well, you can wipe it off. You can wipe it off after 10 minutes.
Right. I think 10 minutes is reasonable.
Ideally, don't wipe off too much.
Not to wipe off too much. Dab it rather than actually rub it.
Absolutely.
How's that?
And you know, with
I'm going to change his practice, folks. I'm going to get him to start dabbing instead of leaving the patient polka dotted. Yeah, I would imagine that with wearing masks, that's certainly
people were thrilled having masks.
from your patient population, I would imagine they were.
Yeah, I mean, nobody could see the majority of injection points, and if they did see, they didn't recognize who it was.
And what do you tell the patients to do once they do get home? I mean, they can wash their face with soap and water. There's no restrictions at all.
Well, no sauna for a week and no sports for 2 days, stuff like that.
Right.
Which I actually don't know what is really valid about that.
I can't imagine that. Those little micro injection points, that they would start to bleed if they really pushed their blood pressure up that high after several hours. I'm sure the fibrin clots have taken care of everything by that time. Those little plugs. I know when I'm injecting, and I'm doing deep injections, for example, I have a technique that I use to go down to the bone to contour the patient, a little zigzag technique so that they don't bleed superficially, and yet when you wipe, right away you start to see blood coming because you've wiped off the fibrin plug from the skin.
Yeah, and you don't know what you're doing on the inside.
Right.
That's the thing.
Well, inside we're bruising them. It's just a question of whether it shows on the surface or not.
So this is the envelope. I got 0.5, which is wonderful for volume.
That's typical, what you would find.
Yep. My favorite point to volumize, which I call the golden point, is just underneath McGregor's patch, nasal jugal groove,
Right.
going to the bone.
Using the same product.
Same product.
Mm-hmm.
And that's the whole idea. The product has the tendency to strengthen the skin if you're intradermal, and it can volumize if you're subdermal. It's the same thing.
Very versatile.
Yes. So I don't care what's on the box.
You don't care.
No, I care where I put it.
Right.
Right? And I feel no resistance on the needle tip here. So I'm going to inject.
And that's sitting on periosteum right now?
Yeah, just hovering above
Mm-hmm.
in loose connective tissue.
Slow injection technique.
One injection, just adjacent. And these are just normal boluses, but I want to make sure I'm not in an artery. We know that aspiration has a 50% false negative ratio.
Mm-hmm.
So that's a little bit too much
For your liking.
for my liking. So these are 2 bowls. And now there are 2.
About how much each injection point? About 0.1?
Yeah. And now they're UFOs. And you see that if you look from that side, the continuous line, now the OG curve is.
Yeah, we can tilt our head just a little bit so you can take a look at that on the back side over there. You can see it very
Reduce
nicely.
the flattening.
Talk about that beautiful OG curve. I guess you're going to come and do the same thing on the opposite side.
She will get angry with me if I don't.
Or she'd pay you twice as much to do the other side.
Well,
There we go.
and she's smart. She said, well, what will we do next time? I said, well, come to Amsterdam.
Come to Amsterdam, you'll find out, exactly.
I'll be going.
So you're just coming up to the end of your first syringe. That's awesome. That is absolutely awesome.
And she's bleeding a little bit, so I'm gonna stop her from
Right,
bleeding.
which is just pressure. I know a lot of people grab ice and start to give the patient ice, but that hurts when you put it against your skin and they hover and they bleed underneath it. Pressure is the answer, just direct pressure. Would you be adverse to using this technique on somebody who's taking blood thinners that cannot stop their blood thinners?
I would warn them.
That they might bruise.
They might bruise.
But
They
that
might
doesn't
red-
prevent you from doing the technique.
No, no. And it's especially that's not a good reason to stop your blood thinners, right?
Agreed.
I mean, this is a medical procedure which is unnecessary.
It's an I want, not an I need, as I say in my practice.
Absolutely. And if you want it and you're okay with bruising more than the average person,
Right.
then I'm okay.
It's not that the patient's going to hemorrhage to death. I mean, if you're on blood thinners, you will eventually clot. It's just that it takes longer.
And it's just a matter of looking into your agenda and making sure that it's possible socially
Right.
to have the bruising for a week.
Correct.
Are you okay?
Yeah.
Nice.
Yeah.
So there we have it. The ferning technique for skin integrity, I guess is the word for it. This was the typical type of thing that you do in your practice. Took them 1 syringe of product to go ahead and to treat the entire lower 2/3 of the face and to also provide some recontouring of the cheeks. And he's going to clean it up gently for us just so we can get a take a look and see. And when you check the skin at the end to make sure there's no areas, for example, that you might have missed, or you did it as you were going along, so I guess you're quite comfortable with what you've achieved.
Yeah, and the thing is, you see some redness here.
Right.
So with the redness, you can expect some swelling, and you can expect some stiffness or strength that will be here while she's swollen and will disappear when the swelling gets
Swelling
minimized.
resorts, yeah. Mm-hmm.
So if you respond to the situation as it is now, you will get into trouble because this is a temporary situation.
Correct. So you tell the patient that for a day or two they should expect
Yeah.
that there will be some swelling.
If she smiles now, you might see a line that's new.
Right.
So you might be tempted to treat that.
That's an interesting point.
Don't do it.
Right.
Because that line might be there because there's too much strength because of the swelling on both sides of that line. So
Gotcha.
just leave it like this.
Oh, that's a very good point to make to our audience, is for them to understand that once you've completed your treatment, that things might not move exactly the same way that you would expect them to move in a couple of days. So, and there's no special thing that you have the patient do when they're at home.
Oh, no.
They don't have to massage, they don't have to feel for any little lumps or bumps or things like that.
No, absolutely not. Massaging will reposition gel.
Right.
And I did my best to put the gel where the gel does not want to go. So if you massage it,
You're defeating the purpose.
Yes, you will force the gel to go into loose connective tissue where it doesn't help you with strengthening.
And you also get the hydration effects of the actual gel as well.
Absolutely.
So they have a kind of glow to themselves.
Well, the skin
When you hear the gloves coming off, it's a good sign. That means that the treatment is complete.
It's successful.
There we go.